Welcome to this comprehensive clinical review of laryngomalacia in children, presented by the Pediatric Case Review channel. In today's session, we will utilize a case-based approach to master the diagnosis, pathophysiology, and management of this common pediatric airway disorder. Our goal is to provide high-quality medical education for our viewers on the Pediatric Case Review YouTube channel. Let us begin. Here is our first question on epidemiology. A pediatrician is reviewing the most common causes of stridor in infancy, which condition accounts for 60 to 75% of all congenital laryngeal anomalies. Option 1, vocal cord paralysis. Option 2, laryngomalacia. Option 3, subglottic stenosis. Option 4, laryngeal web. The correct answer is option 2, laryngomalacia. As shown in the prevalence chart, laryngomalacia is the most frequent cause of stridor in infants, making up 65% of cases. It typically presents within the first 2 weeks to 2 months of life. Fortunately, it is a self-limiting condition in 80 to 90% of these pediatric patients. Question number 2 focuses on pathophysiology. A medical student asks about the underlying mechanism of laryngomalacia. What is the primary pathophysiological process? Option 1, infection of the larynx. Option 2, inflammation of the vocal cords. Option 3, collapse of supraglottic structures during inspiration. Option 4, obstruction by a foreign body. The correct answer is option 3, collapse of supraglottic structures during inspiration. The provided anatomical diagram illustrates how immature or weak supraglottic cartilage causes dynamic collapse. During inspiration, the arytenoid cartilages, aryepiglottic folds, and epiglottis are drawn inward, leading to temporary airway obstruction and the characteristic sounds associated with this disease process. Question number 3 discusses the clinical timeline. A 6-week-old infant presents with noisy breathing that started at 2 weeks of age. At what age do symptoms of laryngomalacia typically peak? Option 1, 2 to 4 months. Option 2, 6 to 8 months. Option 3, 10 to 12 months. Option 4, 14 to 16 months. The correct answer is option 2, 6 to 8 months. The symptom severity graph demonstrates that while symptoms appear very early in life, they progressively worsen and peak around 6 to 8 months of age. Following this peak, most cases resolve spontaneously by 12 to 18 months as the laryngeal structures naturally mature and strengthen. Question number 4 covers the classic symptom. A 2-month-old infant is brought to the clinic. The mother reports hearing a high-pitched sound when the baby breathes in, which has been present since 3 weeks of age. What is the most characteristic symptom? Option 1, expiratory wheezing. Option 2, inspiratory stridor. Option 3, barking cough. Option 4, hoarseness. The correct answer is option 2, inspiratory stridor. This is the absolute hallmark symptom of laryngomalacia. The sound pattern comparison chart shows that this high-pitched, harsh sound occurs during the inspiratory phase due to the collapse of the supraglottic structures. It is often described as a fluttering noise and is best heard when the infant is active or feeding. Question number 5 examines symptom modifiers. Parents of a 4-month-old infant with laryngomalacia notice the stridor worsens in certain situations. Which of the following patient positioning or behavioral states typically worsens the symptoms? Option 1, prone position. Option 2, calm, resting state. Option 3, supine position and crying. Option 4, feeding in an upright position. The correct answer is option 3, supine position and crying. The modifying factors illustration explains that increased respiratory effort during crying, feeding, or agitation leads to greater negative intrathoracic pressure, pulling the floppy tissues further into the airway. Lying supine also worsens the collapse, whereas positioning the infant prone or keeping them calm significantly improves the noisy breathing. Question number 6. During the physical examination of a 3-month-old infant with suspected laryngomalacia, which physical finding would you most likely observe during inspiration? Option 1, expiratory grunting. Option 2, decreased air entry bilaterally. Option 3, suprasternal and intercostal retractions. Option 4, hyperresonance on percussion. The correct answer is option 3, suprasternal and intercostal retractions. The anatomical diagram highlights that significant upper airway obstruction forces the infant to generate higher negative pressure to inhale. This visibly pulls the soft tissues of the chest wall inward, causing retractions at the suprasternal notch and between the ribs. Oxygen saturation typically remains normal unless the obstruction is severe. Question number 7 focuses on the diagnostic approach. A 2-month-old presents with inspiratory stridor since birth. To confirm the diagnosis of laryngomalacia, which diagnostic procedure is considered the gold standard? Option 1, chest X-ray. Option 2, flexible laryngoscopy. Option 3, computed tomography scan of the neck. Option 4, barium swallow study. The correct answer is option 2, flexible laryngoscopy. The clinical illustrations demonstrate how a flexible scope is passed through the nasal cavity of an awake infant. This procedure is the gold standard because it allows direct visualization of the dynamic collapse of the supraglottic structures during spontaneous breathing, confirming the diagnosis without the need for radiation or general anesthesia. Case number 8 explores the specific endoscopic features. You are performing a flexible laryngoscopy on a symptomatic infant to evaluate their airway. As you visualize the larynx during spontaneous inspiration, which specific endoscopic finding is most characteristic of laryngomalacia? Option 1, bilateral vocal cord paralysis. Option 2, an omega-shaped epiglottis and prolapsing arytenoids. Option 3, subglottic narrowing. Option 4, laryngeal papillomas. The correct answer is option 2. The comparative endoscopic images clearly contrast normal anatomy with laryngomalacia. Classic findings include a tubular, omega-shaped epiglottis, significantly shortened aryepiglottic folds, and bulky arytenoid cartilages that actively prolapse into the airway during inspiration. These redundant supraglottic tissues collapse dynamically with each inspiratory effort, temporarily obscuring the vocal cords. Case number 9 discusses associated conditions. A 5-month-old infant diagnosed with laryngomalacia is brought in for a follow-up. The parents report ongoing feeding difficulties and frequent episodes of regurgitation after meals. Which underlying condition is most commonly associated with laryngomalacia? Option 1, congenital heart disease. Option 2, gastroesophageal reflux disease. Option 3, bronchial asthma. Option 4, cystic fibrosis. The correct answer is option 2, gastroesophageal reflux disease. The bidirectional relationship cycle shows that 50 to 80% of cases have associated reflux. The increased negative intrathoracic pressure during inspiration worsens the reflux. In turn, the acidic stomach contents cause significant edema and inflammation of the delicate laryngeal structures, further worsening the airway obstruction and stridor. Question number 10. An infant with known laryngomalacia experiences severe difficulty feeding, displays poor weight gain, and suffers from episodes of cyanosis. Based on these clinical findings, how would you classify the severity of this condition? Option 1, mild laryngomalacia. Option 2, moderate laryngomalacia. Option 3, severe laryngomalacia. Option 4, resolving laryngomalacia. The correct answer is option 3, severe laryngomalacia. The severity classification table emphasizes that the presence of feeding difficulties leading to poor weight gain, cyanotic episodes, apnea, or signs of right heart strain indicate a severe presentation. While most cases are mild, approximately 10 to 20% of patients fall into this severe category and will require surgical intervention. Question number 11 covers initial management. A 3-month-old infant has mild laryngomalacia characterized by audible stridor but demonstrates completely normal weight gain and no feeding issues. What is the most appropriate initial management for this patient? Option 1, immediate surgical intervention. Option 2, observation with parental reassurance. Option 3, intubation and mechanical ventilation. Option 4, tracheostomy. The correct answer is option 2, observation with parental reassurance. The conservative management algorithm dictates that mild cases require education and close monitoring. Interventions include positioning the infant prone during sleep under supervision and managing any associated reflux. Since 80 to 90% of these cases resolve spontaneously by 12 to 18 months, aggressive interventions are avoided unless symptoms progress. Question number 12. A 7-month-old infant with laryngomalacia has failed to gain weight appropriately despite conservative measures and anti-reflux therapy. The child also has frequent cyanotic episodes. What is the next most appropriate step in management? Option 1, continue observation for 6 more months. Option 2, start antibiotics. Option 3, supraglottoplasty. Option 4, bronchodilator therapy. The correct answer is option 3, supraglottoplasty. The surgical indications checklist confirms that failure to thrive, significant oxygen desaturation, cyanosis, and failure of conservative management are absolute criteria for surgical intervention. Because this patient is experiencing life-threatening cyanotic episodes and failing to grow, an urgent surgical approach is required to physically relieve the upper airway obstruction. Question number 13 explores the surgical technique. A pediatric surgeon is explaining the planned supraglottoplasty procedure to the anxious parents of a severely affected infant. What is the primary surgical technique utilized in this operation? Option 1, complete removal of the epiglottis. Option 2, division or excision of redundant supraglottic tissue. Option 3, vocal cord injection. Option 4, cricoid split procedure. The correct answer is option 2, division or excision of redundant supraglottic tissue. The pre- and post-surgery illustrations show how the procedure is performed endoscopically. The surgeon uses microlaryngeal instruments to carefully divide the shortened aryepiglottic folds and remove the bulky, prolapsing tissue from the arytenoid cartilages. This effectively widens the airway opening and boasts an excellent success rate. Question number 14. During a follow-up appointment, the parents of an infant with mild laryngomalacia ask about the expected long-term outcomes. What is the typical prognosis for infants diagnosed with this condition? Option 1, progressive worsening requiring a tracheostomy. Option 2, spontaneous resolution by 12 to 18 months in most cases. Option 3, permanent voice changes. Option 4, development of chronic lung disease. The correct answer is option 2, spontaneous resolution by 12 to 18 months. The outcomes chart illustrates that the overall prognosis is excellent, with 85 to 90% of infants outgrowing the condition as their laryngeal cartilage naturally matures. Even for the small percentage requiring a supraglottoplasty, the vast majority show significant and rapid improvement following the surgical procedure. I would like to personally invite you to join our growing medical community on Patreon, named Pediatric Case Review. This platform contains all of our educational videos conveniently arranged by physiological system for easy access. All the presentation slide decks are available as downloadable files, allowing you to review the material and practice the clinical questions. For subscription details, please comment below. Thank you for participating in this comprehensive clinical review of laryngomalacia in children. We hope these 14 case studies have enhanced your diagnostic awareness and management skills. Please subscribe to the Pediatric Case Review channel for more high-yield, evidence-based medical education. If you have any clinical questions or suggestions for future topics, please leave them in the comments below.